my name is Miley Hewitt, and I'll be performing a 5-view knee exam. I have my tube detented to the table bucky at 40 inches. I'm going to be wagging the tube out of the way so that my patient can safely get on to the x-ray table. So I'm going to go ahead and grab my patient. Alright, Omar?
Yes.
Can you tell me your first and last name and date of birth, please?
Omar Khan, January 30th, 1992.
Perfect. And what brings you in today?
My knee hurts. I fell down the stairs.
Oh, okay. Okay, so we're going to take a few images of that. How long ago did you fall?
Yesterday.
Oh, okay. Any chance you could be pregnant?
No.
No? Okay. Perfect. So are you able to walk on your own?
Yes.
Okay. So I'm going to have you come over to this x-ray table right here. Alright, just sit on the side for now. Alright, so now that we have our patient on the table, we're going to go ahead and do our AP view first. We have our tube detented to the table bucky and at a SID of 40 inches. Because the patient as is to table measurement is less than 18 centimeters, we are going to put a 3 to 5 degree caudad angle. And we're going to go make sure that our table bucky is aligned. Perfect. Right. So our CR is going to enter half an inch below the apex of the patella. There. We're going to make sure that we collimate in on both sides about 1 inch, and then we also want some distal femur and proximal tib fib to show, so that looks great. I'm going to place my left marker with the arrow pointing down on the left side. I'm going to give my patient a shield, and I'll be using a technique of 65 at about 8 max. Hold your breath. X-ray. You can go ahead and breathe. So next we're going to do our medial oblique view. So we're going to long roll the leg 45 degrees medially towards the body. Perfect. Right about there is good. Make sure that we're still at, we are half an inch below the apex of the patella. Keep our left marker there. We are also still using the 3 to 5 degree angle on the tube. Have our patient shielded. And we're going to go ahead and hold your breath. And x-ray, go ahead and breathe. And if I didn't say my technique on that, it was 65 at 8. And now we're going to go ahead and do our lateral view. So I'm going to have you turn over onto your left side. Perfect. Alright, so we're going to flex the knee 20 to 30 degrees. Perfect. And that's to relax the muscles and open up the joint space. So for this one, we're actually going to angle our tube to valid 5 to 7 degrees. Perfect. Still CR under. Move your knee back just a touch. There you go. Perfect. And then we're going to put our left marker on there. And for this one, we're still going to use 65 at 8. We're going to shield our patient all the way. And then go ahead and hold your breath. an x-ray. Alright, you can go ahead and breathe and relax. So we're now going to do now we're going to go ahead and do the Claire method. We have the patient's leg flexed at 60 degrees. We are going to angle the tube perpendicular to the long axis of the patient's lower leg. We're going to make sure that we're not on table bucket anymore. And wide. Alright, there we go. So we're going to do the central rate at the level of the knee joint. Column it in on both sides. Make sure we have a marker. So we're going to use 75 kV at 12 mass. Go ahead and hold your breath. X-ray. Go ahead and relax. So now we're going to go ahead and do the Sedigas method to see the patellofemoral joint. We're going to have our patient, I'm going to scoot this table back as far as it goes. I'm going to have our patient sit up. Move this tube out of the way. I'm going to have you put your foot right here, okay, and then flex it as much as possible. Perfect. I'm going to have you hold this plate right here, and maybe scoot your bottom forward a little bit so we can get a little more angle on your leg. I'm going to put my left marker on there. And so the angle on the tube is just going to be perpendicular to the patellofemoral joint. We'll go forward. Yeah, perfect. Nice. We'll go this way. I still feel like that's gonna be alright, perfect. And then we'll go ahead and shield the patient. We'll be using a technique of 60 at 6 mass. Go ahead and hold still. Actually, probably in a little more. Right. Alright, go ahead and X-ray.
Now that we have completed our x-rays, we want to check our images to make sure that they are of acceptable quality. This image displays our AP knee, and we want to make sure that we can see the necessary structures, such as the distal femur, the patella, the femoral condyles, the intercondylar eminence, the tibial plateaus, the tibia, as well as the fibula. For an AP knee, we should not have any rotation, and we can check this by seeing that the patella is superimposed over the femur. The fibular head should be slightly superimposed by the tibia, as well as symmetrical femoral condyles. Our AP knee should also show an open fibular tibular joint. Next, for our AP oblique knee with medial rotation, we want to make sure that we can see the same structures as our AP knee, which include the femur, the patella, the tibia, as well as the fibula. To identify this as a good AP oblique knee with medial rotation, we want to see the patella slightly projected over the medial border of the femur, as well as an open proximal tibial-fibular joint space. This shows that we had good rotation of the knee and an overall good oblique image. For our lateral knee, we must make sure that we can still see the same structures we have in the AP and oblique. So we want to see the femur, the femoral condyles, the tibial plateaus, the tibia, as well as the fibula. For our lateral knee, we should make sure that we can still see the same anatomy as the AP oblique and the AP view of the knee. We want to make sure that we can see the femur, the femoral condyles, the patella, the tibial plateaus, the tibia, as well as the fibula. In order for this to be a true good lateral, we should see the patella in lateral profile as well as the open patellofemoral joint space. We also want to make sure that the femoral condyles are as superimposed as possible. We should also see a slight imposition of the fibular head and the tibia. For our AP axial intercondylar fossa view, we want to make sure that we can see the necessary structures, which also include the femur, the femoral condyles, the intercondylar fossa, and the intercondylar eminence, as well as the tibia and the fibula. In order to know that this is a good image, we want to make sure that we can see the intercondylar fossa open, since this is what the image is taken for. We want to make sure that there is no superimposition of the apex of the patella. Lastly, our tangential projection of the patella. You should be able to see the patella as well as the patellofemoral joint. In order for this to be a good image, we want to make sure that our patellofemoral joint space is as open as possible.